All right. So we are here today to discuss inflammatory bowel disease. And I'm going to try and make this as exam kind of focused as I can to try and make it as case relevant as possible, because obviously what the exam, particularly membership exam, is testing is really how you approach cases. So we're going to start pretty broad with kind of how you work up diarrhea, and we're going to try and work through that really quickly. So I want you to throw out answers as quickly as you can just to try and work through that stuff. And then we're going to move on to the specific forms of inflammatory bowel disease and how we kind of classify it and how we manage it as a primary importance for exam answering. Josh, I really want to ask how you're feeling. Sorry.
I've definitely felt better, that's for sure.
Josh has COVID. I'm very impressed you're here, but I won't pick on you too heavily.
Here to listen more than anything, I think.
All right, noted. Matt, you're my next target. Okay, so let's just talk a little bit broadly about inflammatory bowel disease. Does anyone know what, we sort of say inflammatory bowel disease? What does that mean?
Idiopathic.
It's one form, yeah.
I've seen it.
Inflammation.
Yeah, exactly. It's a really
clinical signs.
Yeah, really non-specific term, inflammatory bowel disease. And it can apply to inflammation anywhere in the small or large intestine. And there are a lot of different causes of it. And I think it's really good for me clinically to have in my mind, these are the different categories that when I'm thinking that a patient has symptoms consistent with inflammatory bowel disease, these are the different categories that might fall under. So Matt's mentioned one, idiopathic inflammatory bowel disease. That's one of my categories where there's no really underlying cause. Can anyone think of any others?
I've seen it divided into three: antibiotic responsive, diet responsive, and pred responsive. Exactly.
So pred responsive is typically the idiopathic one that doesn't respond to the diet or antibiotics that we've trialed. Now, this is an interesting classification system given what we were talking about last fortnight, in that we sort of say antibiotic responsive, and I think that's probably going to be updated in the next review to be manipulation of the microbiome responsive, IBD. And then there's actually a fourth category, which are all of the weird genetic ones, like the breed-specific IBDs, which have underlying genetic causes. So 4 categories. Does anyone want to give them to me again?
FRE, ARE, the idiopathic, breed-specific.
Good, excellent, good. And FRE, food responsive, ARE, antibiotic responsive. Is that what you said? Yes, great. Yeah. Excellent.
And is the nomenclature nowadays chronic enteropathy like as an umbrella term for those four etiologies, or is it still inflammatory bowel disease?
So it's inflammatory bowel disease. Okay, that's a good segue. What is the WASAVA criteria for diagnosing inflammatory bowel disease? That umbrella term, so not the sort of subtype or etiology, but the overall form.
Infectious exclusion.
Yes, infectious and neoplastic. I'll throw in there as well, as well as extra gastrointestinal causes of gastrointestinal signs. So what might they include?
PPI.
Yeah. So that's probably the main one.
Renal.
Beg your pardon?
Renal.
Renal, good. Yeah.
Sorry, I've had 2 coffees, so I'll let someone else jump in.
Every now and again with my team, we rate our energy level at the beginning of the day, just so that I know how hard I can push them. That's a 9.
Well, Addison's disease can...
Excellent. That's what I was looking for. Yeah. So that's probably one of the more common causes of chronic gastrointestinal signs. So we've excluded extra gastrointestinal and non-inflammatory gastrointestinal causes of bowel symptoms. What other criteria are there? Duration?
More than 3 weeks.
Beg your pardon?
More than 3 weeks.
Great. Excellent. Very good. What else?
You probably have to have a significant, I guess, is that where you might add up whether there's vomiting and diarrhea to get a certain amount of pathology? Is there a minimum criteria in terms of level of like burden of symptoms?
There's not actually, interestingly, but there probably should be. I mean, it's not, you know, having a bout of diarrhea after he eats the kid's scraps off the floor probably doesn't count.
It's a histological diagnosis, so you have to prove that this infiltration of various cell types.
Exactly. So we have to have histologic evidence of inflammation to call it inflammatory bowel disease, because then that chronic enteropathy that Matt was discussing is then another umbrella term that sits over the top of inflammatory bowel disease and describes both non-inflammatory and inflammatory symptoms. So we've got 3 things. We've excluded other causes. We've got histopathologic evidence of inflammation, greater than 3 weeks duration. What about responsiveness to treatment trials?
Unresponsive or partially responsive.
To which ones?
To probably food trials and antibiotics, antimicrobials.
Excellent. And then the 5th one is actually responsiveness to treatment trials. Which treatment?
Corticosteroids.
Good, exactly. So that's the criteria for calling an idiopathic inflammatory bowel disease inflammatory bowel disease.
And does exclusion of B12 deficiency sit above like with part of that exclusion criteria? Would that sit in that category, or would that be sort of more downstream?
That's such a good question, because it's not really been established definitively as having causation for inflammatory bowel disease signs. But we know more and more that deficiency impacts gastrointestinal
correlation.
Yeah. So great segue again, Matt. Let's move into diagnosis. So say you've got a dog with chronic diarrhea, and anybody that is doing past papers, I was just speaking to Tiani, apparently there was a 30-mark question last year on your approach to, was it a dog with chronic diarrhea?
Yeah.
30 marks. It's like a 1/5 of the paper or something, isn't it? It's just huge. So it was literally a 1-line question. Like, that
was the first question as well.
Was it?
Yeah, paper 2.
That is crucial. That would do me in, I reckon. So we're not going to go into too much detail, because the chances of it being asked again for those who are examining are really, 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 really slim. But it's really good to have in your mind. You see this all the time. You know, you've got a dog with diarrhea. What do you do about it? We've talked about cobalamin just now, so we'll start there. Do we test cobalamin in patients with chronic diarrhea? Does everybody do it?
We should.
We should. Yeah.
I don't. I never have, and I'd like to be convinced one way or the other.
Okay, good. Let's do it. I always forget. Yeah. It's one of those things. It's one of those like black holes in my mind that after I do a workup, I'm like, damn it, I should have done that. But more and more we should. Why?
I feel like because it might be contributing to signs, I don't know if there's any diagnostic value in it, but only in terms of a therapeutic value, potentially.
So I mean, I do a response to cobalizorb as part of like a treatment trial with cobalizorb nowadays a lot. And I guess it depends on budget, because B12 is expensive in Australia. But I think it helps see if there's refractory disease, then it helps improve the treatment outcomes. So maybe not. Do
you do that in isolation as your, like, or do you combine that with other treatment trials? Like, do you know which they're improving from?
Ooh, good question.
No, not necessarily, but normally when I get cases, it's kind of for refractory disease, and so that's definitely one that I'd follow up. If the B12's never been documented, then I'd be like, well, that could be the missing link in why we're not getting the treatment response that we want.
Yeah.
Is the testing for it more expensive than the treatment of it?
No.
Isn't it
Hugely.
Oh, sorry, I was just going to say that, isn't it, it's quite helpful in knowing the severity and potentially which parts of the small intestine may be affected. So if you've got a low cobalamin, I mean, it means that as long as your pancreas is functioning normally, you're more likely to think that you've got small intestinal or more specifically ileal disease. So you're starting to think of those kind of protein losing enteropathies or more severe IBD. And if it's low, as Matt said, treating it's probably a good idea, because I think, and Anna, I can't remember exactly, but it's I think it has something to do with you get more like methylmalonic acid or something acidic causing more irritation in that area. So you get more diarrhea. So treating it's always good as well.
We may have just officially tipped to Josh knowing more than me.
I know.
I don't know what you're talking about. So methylmalonic acid is involved in the Krebs cycle, and certainly B12 deficiency is associated. It's one of the cofactors in the Krebs cycle. So it impacts energy production and nutrient utilization if we're cobalamin deficient. But I would never have remembered the methylmalonic acid bit, so I'm very impressed, Josh. And as far as localization goes, I agree that cobalamin deficiency is a marker of severity of clinical signs. Not of clinical signs. So you can have a dog with 0 clinical signs and quite severe cobalamin deficiency and severe gastrointestinal inflammation. But it is a marker of severity of inflammation and bowel function. So it's a marker of actual function testing rather than, all the other stuff we test. You can have 0 inflammation and really severe diarrhea. So it's a nice marker of that. So there's a good paper that looks at cobalamin as a prognostic indicator, and it's one of the most accurate prognostic indicators. So if it's low, less than 200 nanograms per litre, it is associated with a negative outcome and decreased responsiveness to therapy.
What about testing for folate?
Good. Why would we test for folate specifically?
Well, that's absorbed more in the proximal small intestine.
Yep.
The way I try to remember is folate's first and then B12 is further down.
Yeah. And this is why I wanted to talk about the cobalamin and folate up front so that everybody's kind of front of mind, is because our understanding of the bowel is shifting towards the microbiome having more of an impact. How do you get folate in the lumen of the bowel? Is it just from food?
The bacteria, mycobacteria make it. The
Good.
microbiome make it.
Yep, exactly. So when we test folate, we're not just testing absorption, we're testing the function of the bacteria in the bowel. So how often do we see a low folate level?
I don't see it very often.
No, it's
normally see high.
Exactly. It's virtually never seen because there's so much folate being produced in the bowel. So traditionally, we've sort of thought of folate and cobalamin testing as if it's low, it's significant, it indicates decreased absorption. Whereas now that our understanding is improving, I think that we're going to see a swing back to people testing for cobalamin and folate as a routine, because actually being high is significant. So it doesn't indicate absorption abnormalities, but it might indicate a shift or an indication of the type of bacteria we've got in the bowel. Okay, so cobalamin and folate, and I will just note in there as well, because it was traditionally, the ratio of cobalamin to folate was traditionally used in cats to localize their inflammation. And it's been shown that it doesn't actually localize inflammation. So the value I think we get out of it is there any therapeutic benefit to supplementation with cobalamin? Or do we potentially have what we traditionally thought of as SIBO, small intestinal bacterial overgrowth, or dysbiosis if there's a high folate.
And with is there any association between looking at more of the non-inflammatory chronic enteropathy pattern versus going down the kind of diagnostic algorithm for IBD to get a sense check? Like if there's a high folate, low B12, or normal B12, high folate, would it maybe decrease your clinical suspicion of IBD a little bit at the first sort of sense check, and sort of look more at a functional disorder? Or you just like it doesn't really have a place in that high up in the algorithm? It's
a good question. Let's tackle that when we move on to sort of treatment. Because it's certainly, when we're doing treatment trials, it certainly would make me lean towards manipulation of the microbiome as opposed to, going down the biopsy route at that point.
Yeah.
And trying to get meet the criteria for IBD.
Yeah.
So we've got, as far as the diagnostics we're going to do in our dog with chronic diarrhea, we've done a physical exam. You don't have to talk about that. It's normal. We've done a cobalamin and folate level. What else are we going to do?
Check basal cortisol, rule out hypo-A.
Super. If we're in an exam, are we just going to do basal cortisol, or are we going to do a full stim?
So I would think money plays a role. So if you just do basal cortisol and if it's above 55 nanomoles per liter, you've ruled out hypo-A. But if it's low, then you will need to do an ACTH stim.
Okay, excellent. So as an examiner, I've got an answer key, and on my answer key, ACTH stim test is 1 mark and basal cortisol is 0.5 mark. So you've justified that beautifully, but you've had to use 5 minutes justifying that. Whereas if you've just written stim test, money doesn't matter in an exam. So just you're right, gold standard in the exam. So definitely, but clinically, I'm definitely going to do a basal cortisol. That's exactly what you do, because that's unrealistic.
I mean, would you want minimum database before then, like biochem, CBC, T4 if it was a cat, and then also fecal PCR plus parasitology with cytology?
Excellent. So Matt's just got 5 marks. What are we looking for in our CBC?
A leukogram change, or lack of stress leukogram to inform going for to justify an ACTH stim.
Yeah, excellent. What about eosinophilia? Good, excellent. Particularly in cats. What about if the patient was profoundly B12 deficient?
Anemia, microcytic anemia. Macrocytic, sorry.
Macrocytic, yeah. Excellent, good. What about in our biochem? What are we particularly interested in a dog with chronic diarrhea?
Albumin.
Albumin.
Good, excellent, yeah.
BUN.
And then obviously looking for markers. Beg your pardon?
Electrolytes, ALT.
Good. Yep. Yes, exactly. So extra gastrointestinal causes of gastrointestinal signs. So
cholesterol that plays a role somewhere. Cholesterol, but I can't remember. I think it'll be low. Or would it be high?
Yeah, it can be low. Absolutely. Yep. Now talking about ALT on our biochem, how do you know if an ALT elevation is reacting to the bowel problem or the cause of the bowel problem? So we're trying to sort of rule out extra gastrointestinal causes of diarrhea.
Less than 300.
Level.
100.
Matt, do you use 300?
Me?
Yeah.
Yeah, I mean, if they've had any chronic like vomiting or diarrhea within 2 weeks, less than 300, I'd be less inclined to think it was primary hepatopathy.
Yeah. I use 800. I'm a little bit more.
Oh, okay.
Yeah. So if it's over 800, I'm usually sort of suspicious there's more of a primary kind of hepatopathy going on. If it's under 800, then it's documented as being kind of reasonable to assume it's a reactive enteropathy, a reactive hepatopathy associated with an enteropathy. That's very much, there's a lot of grey area there. And Matt and I are dealing with a patient who consistently had ALTs over the 1500 mark, and it was diagnosed by biopsy in the liver as a reactive hepatopathy. So it's certainly not a hard and fast rule. But yeah, it's a good indication if you're sort of saying, am I going down the bowel route or am I going down the liver route? But certainly good to note when you're doing imaging.
What on biochem also, I don't know if this is super old school, out of date, but what about like getting some footprints of amylase and like high enzyme level to sort of move forward with pancreatic interrogation?
It's such a good question. Is my sound all right? Yes.
Yeah.
I just heard myself echo, and my kids are really loud this morning. I don't know why. Sorry. I don't really even know how to answer that, because you still look at it and you see a high value and you go, oh, that's pricked my interest. But the studies literally say it's pretty much 50-50 whether it could be significant or might not be significant, essentially. So you might as well flip a coin and say, is the pancreas involved based on those numbers?
Well, beyond that, would you, as a workup of IBD, would you want to scan the pancreas and do a CPLI or FPLI anyway as part of the workup?
Yes, absolutely. I think it's never going to go astray having that extra information. Did we ever see CPLI elevations when there's inflammation adjacent to the pancreas?
Yes, yeah. All the time.
All the time, exactly. So it's not a good test for pancreatitis in the presence of a chronic enteropathy.
Yeah.
So certainly I would note that my interest, so if I was writing an imaging request, for example, for an ultrasound, I want to assess the liver to assess my reactive hepatopathy. I want to assess the pancreas to see whether there's any association with the bowel signs, or any localization of inflammatory changes in the bowel adjacent to the pancreas, which might explain my high CPLI. But I'm going to form a big picture of this rather than sort of saying one test result, it is pancreatitis.
Sure.
Good. So CPLI. What other pancreatic testing would we want to do?
TLI.
Good. Excellent. What about?
Would you only do that? Would you only do that if you had stool set, like a characteristic stool, or is that not very specific or sensitive test?
Early in the course of EPI, you'll have not undigested food coming through, and it's not necessarily greasy or anything, depending on the quality of the food that they're giving. Particularly cats can have EPI with vomiting and no diarrhea. They just do it all differently. So it's a very expensive test, so it's hard to sort of get it over the line, but it's definitely something that I would want to do, even with with any form of diarrhea, basically. And the other thing is, owners aren't very reliable with their descriptions of poo. So when you ask them if it's greasy, they're like,
they don't have photos on their phone to show you?
Well, that's your clients, man.
I'm more like, I believe you. I don't need to see the photo. Let's move on.
No, I do have an email account full of poo photos.
The breed can give a clue sometimes to API.
What can, sorry? The breed. Absolutely. Yep. What breeds?
Shepherds.
Shepherds.
Good. Excellent.
And would a high folate SIBO pattern sort of increase your suspicion of EPI as well, to sort of rationalize a TLI test?
Yeah, absolutely. Yeah, that's a really good point. So a low cobalamin to folate ratio, so decreased cobalamin absorption and a higher folate level in particular would prick my ears. Absolutely. Why am I interested in cobalamin with regards to EPI?
I think it's the pancreas. It's maybe the pancreas or something. The pancreas are involved somehow. I can't remember how.
It is
intrinsic factor failure.
Yes. Yes.
Excellent. Yeah. So cobalamin is transported in the lumen of the intestine bound to intrinsic factor, and it can't survive the digestive process without the intrinsic factor bound to it, and it can't bind and be absorbed without the intrinsic factor bound to it. So If the pancreas is dysfunctional, then the cobalamin doesn't get absorbed in the same quantities at the ileum. And obviously that's a spectrum, like the pancreas doesn't just stop working one day and stop producing intrinsic factor. The amount goes down sort of really gradually. So the amount of cobalamin absorption capacity is going to go down quite gradually as well. So we're not going to see it on day, 400 where there's zero pancreatic function. We're going to see it somewhere on that spectrum.
And then on TLI, are you saying like early stage that you wouldn't have any under conditioning, body condition score deficits? I mean, would that flag you more than an IBD that isn't in low body condition score yet?
I think as a GP, you'd be able to trend the condition loss, but quite often we've seen dogs that were obese who are now
gotcha.
body condition, exactly, or like, lean muscle score, but you don't know what they were like before. So when you're seeing them as a first line, I think it's hard. Obviously, when they're emaciated, it's very obvious, but on that spectrum, again, they've got diarrhea for a long time before they become emaciated. And we're quite often, the way that people live with their dogs now, quite often seeing them earlier in the course of disease. What about if this was a cat? Do we want to do any viral testing? Probably, always. Yeah.
Yeah, I mean, would it depend on your A to G ratio on the bloods, or not even? I mean, you do FE or FIV pretty much for any sick cat by this stage, wouldn't you? For a money doesn't matter exam question.
Exactly right. Yeah, exactly right. So if I'd said this was a dog when we started, but if we said this was a cat, I'd definitely put FIV, FE, or V. Now, Matt, you mentioned T4 for a cat. I would type that in for a dog as well. Because every now and again we have dogs with functional thyroid carcinomas, and it's very exciting when they flag high. And the other thing that's sort of more common with raw feeding is that there's been reports of thyroid tissue in the food and hypothyroidism associated with ingestion.
I've seen that.
You've seen it, yeah.
Once.
So that's where the nice, sending out to the lab where you get a profile with a T4 in it is just really nice. And you go, it wasn't really on my differential list, but let's talk about that now.
Right. So you're talking about excessive thyroid hormone in a dog.
Yeah.
From a functional carcinoma or from the raw food.
Yeah.
So how are you going to tell which one it is? Are you going to ask them if it's raw food and stop it and retest? Exactly.
Yeah. So it depends how badly affected they are, but they're really, really hypothyroid and there's a palpable mass, because normally when there's a thyroid carcinoma, you can feel it in a dog. Then I'm certainly going to go down the road of chasing that. But if their history of raw feeding, particularly low quality and sort of not responsibly prepared raw feeding, then absolutely. Yeah.
High consumption of chicken necks that aren't deglanded would increase my suspicion. Or if someone was feeding glandulas like thyroid offal, that's what the history taking that I would be looking for.
Yeah. I hadn't thought about the chicken necks. That's interesting.
Oh, that's where I saw it was a little Jack Russell that was eating chicken necks as 50% of their ration every day for years.
Wow. You'd see that in cats too, I guess. They get a lot of chicken necks.
Yeah.
Yeah.
Interesting.
So you'd be thinking about iodine. And the other area to think about with iodine is if they're using dental chews or plaque off, that sort of thing. For both high and low.
Interesting.
How long do you have to stop the feeding to retest?
It's got a pretty short half-life, so I would probably say 2 weeks.
Okay.
Yeah.
I doubt that anyone's going to see that in clinic.
Right, it's pretty rare.
The raw food one.
Hypothyroidism, do you mean?
Raw feeding associated high hyperthyroidism in a dog or a cat. I reckon it'd be so rare.
Be a good one for an exam though.
Yeah.
Okay, so we've sort of gone through all of the background testing we want to do when we've got a patient with chronic diarrhea.
Are you going to do PCR and talk about rectal cytology?
Actually, good one.
Because I don't know the value of those anymore.
Yeah. So Matt actually mentioned fecal PCR and parasite testing for infectious disease. I think it was Matt. Yes, I'm going to do them. There are a lot of things on the PCR that might flag positive that I wouldn't attribute the signs to. For example, like Clostridium overgrowth sort of thing, or high Clostridium DNA levels on a fecal PCR is not actually correlated with the incidence of diarrhea, and therefore is probably an insignificant finding. I note it as the kind of big picture thing, but I do the PCRs, particularly in dogs that have kind of 4-week history or have been very healthy adults with no history of gastrointestinal upset that have a kind of even a 3-month history. I'm more suspicious of something weird going on there. And certainly parasites. There's a new, I can't even remember the name of it, but it's like an in-house fecal analyzer, which is kind of increasing our diagnostic capacity to detect worms. And there are actually more worms in Sydney than we thought. We thought there was pretty low worm burden, but, you know, doing the routine Drontal and stuff like that has probably kept the burden low, kept clinical signs low, but there are quite a few worms around.
Are we looking for adult dogs in terms of symptoms, just whipworm or anything?
I don't even know, Bron. I would say, you know, just like chronic diarrhea, but are you asking which worms I'm looking for?
Yeah.
Oh, I don't know. Sorry.
Well, they're using Mayo Clinic's researching helminth therapy for IBD. So these patients that are IBD probably don't have worms.
Yeah.
Yeah. Interesting.
Yeah, I did see a very heavy whipworm infestation in Wagga. In fact, I've got some nice photos of it. Was referred for colonoscopy for chronic large bowel diarrhea, and there are just hundreds and hundreds of them in there. But that would be exceptional.
And I knew a human that went in for a scope and was diagnosed with worms.
What were they a vet?
I'm not telling. It gave me great pleasure.
It's a different species, of course.
Yeah, of course.
A worm, I mean.
Yes, a worm. Exactly right. Yeah. Yes. So as far as sort of parasites and things, essentially, when a dog's not that unwell, if I've got an abnormality on my fecal test, then I sometimes sort of say, use that almost as ammunition to say, okay, well, then we're going to manipulate the microbiome because it looks like we've got an overgrowth of Clostridia sort of thing, knowing in my mind that that's probably not causal and it's probably not really, you know, the problem. But I can use that as a kind of tangible thing to explain to clients, this is something that we need to manipulate. You can see that there's an abnormality here, and we therefore need to really pay attention to diet and probiotics and do this trial, just, I guess, to get buy-in more than anything else. But there's very few pathogens that we detect on those fecal PCRs that I will say all of these signs are a chronic enteropathy.
And Trichomonas fetus in a cat, is that going to be relevant?
Probably
that's the most relevant thing in a cat PCR.
Much. Yeah, absolutely. And interestingly, Trichik is pretty self-limiting most of the time.
Right.
A lot of cats are carriers after they've been infected and had their kind of 2 weeks of diarrhea, but some cats can have very long-term diarrhea with Trichik. So that's something I would absolutely, if I detected that, I would absolutely treat it as well, because if they're carriers, if they're not affected and they're carriers, then they're going to pass it on to other cats in the household.
And will those cats that are chronic sufferers from Trichik also respond poorly to corticosteroids?
Yeah, good point. Yeah. So if we're kind of looking at the route of treating an infection versus immunosuppressing, absolutely treat the infection first, for sure. That's a really good point.
So is it prudent though to rule Trichik out before commencing corticosteroids in cats?
Yes, definitely. How do you rule Trichik out?
You can just make a wet prep and look under the microscope because you can see them floating around.
You can. Are they always in feces?
No.
Can they be in colonic plaques?
Yes. So they live in the enterocyte, in the colonocytes. So it's actually we get a lot of false negatives with Tri-Trick because they're just not exfoliated into the feces. So PCRs, we get false negatives all the time. There's a specific technique described for doing your PCR if you're very suspicious of Tri-Trick, which is if you've got sort of advanced warning, you can administer lactulose orally. And then 24 hours later, you put a catheter 10 centimeters into the rectum colon, put 10 mils of saline in there, swoosh it around. So per abdomen, percutaneously, like agitate the colon around your catheter so that you're almost abrading the colon, and then suck your saline back out. And then you're getting colonocytes in your sample, so more likely to get a positive PCR. So that's one thing that is definitely worth ruling out.
Is that technique used for E. coli, like adherent E. coli in dogs as well?
The trouble with that is we're doing a PCR, you're going to get a positive on E. coli.
Sure.
Yeah. So if you could get cells and then isolate those cells in that sample and then do FISH or something like that, that's going to detect bacterial DNA within the cells, then that would be significant. But a PCR is not differentiating what's inside the cell and what's in the lumen.
Yeah, gotcha.
Okay, we've done all our peripheral testing. We've not come up with any reason for this dog's diarrhea. What's our first trial going to be? Well, what's our first treatment option going to be?
Depends on how sick the animal is. If the animal is relatively healthy, then you can start with maybe fenbendazole food trial. If the animal is sick, you need to sort of move faster and do some more diagnostics. Maybe.
I completely agree.
When I say diagnostics, I mean maybe.
So I missed all of that. Purge's sound was distorting.
It's my internet connection.
So I think she said it really depends on whether the animal's well or not. So if the animal is well but with diarrhea, then you've got the luxury of having the time to do the fenbendazole trial, food trial. Was that right, Pooja? That's what you said?
Yes.
Yeah.
Yes.
Whereas if the animal's unwell, you probably need to do more invasive diagnostics sooner. What classifies as unwell?
Losing weight drastically, like rapid weight loss.
Yeah.
Maybe if the albumin is low.
Good. Yeah.
Attitude and on a activity index, looking at the attitude of the dog, is there malaise, is there vomiting plus diarrhea, is there, I don't know, if like blood in stool is no longer sort of classified as like as a way to kind of increase the severity, duration for more than 3 days.
Yeah. Excellent. So does everybody know what the IBD activity index is? Yeah, great. It's a really nice way of scoring, kind of making the severity of IBD a little bit more objective, particularly visit to visit. I just get the clients to do it every week, once a week, score how severe the signs are, and we can use that to guide whether we need to be more aggressive about diagnostics and treatment. So say we did have a dog with albumin of 17, low end of the normal range is 23, and severe weight loss, 20% of the body weight over the previous month. And the globulins were also borderline low. What's your approach to this? Are we going to do a diet trial or are we going to go straight into biopsying?
I think with this dog, obviously check the urine just to make sure it's not protein losing nephropathy as well. And then I think with this dog, yes, I go for biopsy straight.
Okay. I led you into that, but is there any other testing, non-invasive testing you'd like to do before biopsy?
We've done the TLI and all that already, haven't we?
We've done all the blood.
I would ultrasound first.
Good. Excellent. Yeah.
And diet trial.
Would you diet trial in a protein that low?
Well, actually, I mean, if you're setting up for the ultrasound, albumin 19, I mean, and it's not on a hydrolyzed diet, I probably would put it on a hydrolyzed diet immediately, unless I was going to like admit it and work it up, I guess. Yeah, probably not. I don't see these kind of cases, so yes, probably not.
I get really nervous about protein loss. If I see low protein, I'm pretty aggressive about finding out why before doing trials. And if it comes back eosinophilic and like it's going to respond to a diet trial, then we go down that route. But typically the degree of inflammation, if you think about if you had an abrasion on your skin and you were losing so much serum, like a burn or something like that, you were losing so much serum to become hypoproteinemic, that's the sort of degree of inflammation we're talking about inside the bowel. So if you sort of put a visual to it, you sort of think, whoa, this is pretty severe. We probably need to work out what's caused this, particularly if it's quite sudden onset. When we talk about PLE, what are the kind of categories of causes of protein losing enteropathy?
Lymphangiectasia and inflammatory bowel disease.
Yep.
Is that it?
One more.
Interception, but I don't know how chronic interception maybe.
Good one. So I would say that probably falls under inflammatory, but like reactive appropriate inflammatory.
What about malnutrition from hyperexia?
Good, but it's not a protein losing enteropathy. It's
right. Okay.
Yeah. So it doesn't fall under that umbrella. There's one more big one.
Lymphoma?
Yes. Neoplasia. Exactly. Yeah. So it might not just be lymphoma. There's other sort of focal masses which can cause particularly blood loss. Typically they're anemic as well, but they can get quite hypoalbuminemic with neoplasia as well. So those are the three things. So all of those, if we've got either neoplasia, we need to know about it sooner rather than later. If we've got inflammation severe enough that they're losing, half of their protein into their bowel, also need to know about it sooner rather than later. And lymphangiectasia is associated with sudden death and has a very poor prognosis, and therefore we should know about it sooner rather than later. So the three of them are really severe syndromes. And obviously inflammatory bowel disease, if it's just inflammatory, it's a spectrum, it's not a severe, there is a better prognosis than the other two. But certainly I want to rule out the other two, so I'm more aggressive about looking into things. So when you do an ultrasound in this patient with his low protein, what specific things what information are you wanting to gain when you write your request form?
Intestinal wall architecture.
Yes, excellent.
You want to know if there's focal abnormalities or diffuse.
Excellent.
Yeah, lymph node status.
Mm-hmm.
Mesenteric lymph node status.
Excellent. And how are you going to decide if we're sort of saying we want to go down the biopsy route? How are you going to decide whether to use endoscopy or surgery in this patient?
It partly also depends on the location, because if it's diffuse, then you can get good samples with endoscopy. With cats, I've heard though people say that surgery is better, so I don't know. I think it would also depend on finances. Come back to that.
Yeah, unfortunately.
Let's say if there is a focal mass, as we discussed before, then you could do a fine elaborate ultrasound guided, because if it's lymphoma, you find out.
Excellent. Yeah.
Anna, do you have much trouble with wound breakdown doing biopsy on low protein dogs or cats?
Yeah. What's the cutoff there? Or...
Absolutely. So there's a paper that came out fairly recently that says that dogs with albumins over 15 have no increased incidence of complications with surgical biopsies as opposed to other dogs. I would argue logically that probably that sample size wasn't big enough to demonstrate negative outcomes. I think logically we know that there's going to be compromised healing, and we know that dogs that are losing albumin are also losing antithrombin and their endogenous anticoagulants, and they're very hypercoagulable. So while stroke is a very uncommon complication and it would be very hard to attribute it to the PLE, I think if you've got a sample size of 100, you can say, yeah, no decrease in no increase in risk. But I think if you've got a sample size of 10,000, you'd probably be demonstrating an increase in risk. So we know that as clinicians and that veterinary studies are compromised. But technically, we've got sort of data to say that over 15 is a reasonable risk to take. As long as it's over 15, it's a reasonable risk to take to do surgical biopsies. The other thing that really sort of I'm looking for when I do an ultrasound in these patients is the location. So if I've got pretty normal stomach, duodenum and jejunum, but I've got a really thickened ileum or distal jejunum, I know that scope's just not going to get there. So in that situation, I'd probably push for a surgical biopsy. If there's lymph nodes affected and I want them sampled as well, then obviously surgery is the way to do that, because endoscopy, we're not going to get that. Or if there is a sort of focal abnormality in the proximal bowel, but it's submucosal, because bowel biopsies only get the mucosa, then I would push for a surgical biopsy as well.
Anna?
Yeah.
Is this the association of sudden death with lymphangiectasia? Is that having to do with hypercoagulation?
I think so. In my mind, there's only two real causes of sudden death: thromboembolic or arrhythmia.
Okay.
So it has to be one of the two. Theoretically, they could get arrhythmias, because we know with, like dogs with GDV and things like that, when they get really potent inflammatory cytokines going into their venous return, we get arrhythmias associated with that. So in theory, it could be arrhythmia associated, but I would say much more likely thromboembolic.
When you're early treating these patients with hypoalbuminemia, do you ever use clopidogrel?
Really good question, because I would love to, and I think that's exactly the right choice of anticoagulant for these dogs. But so often we're looking at doing invasive procedures, and you can't reverse clopidogrel. And
all right,
yeah, if they've had, particularly if we're looking at going to surgery, you'd need to do at least a 1 week, preferably 2 week washout, and that just delays the onset of being able to start treatment and things.
So your treatment's going to take care of it, because it's going to be pred or whatever responsive anyway.
Exactly. Yeah, exactly. So then let's talk about the other sort of difference between surgery. We've got healing, obviously, and compromised healing. The other problem with surgical biopsies is that usually we don't start immunosuppressants or prednisolone until 2 weeks afterwards. So if we've got a very critically unwell dog, we really can't wait. So we either have to make the choice to further compromise healing, but get a really good diagnosis and biopsy by starting the pred earlier, or we need to know that the dog's going to be safe for that 2 week post-op period and that we can start the pred then. So I think there's no sort of right answer about whether to do endoscopic or surgical biopsies. You've just sort of got to weigh up how sick the dog is. And in many patients, we don't get a chance to do biopsies because they're just too unwell, and we need to start them on something to decrease the inflammation and then get to the bottom of it later. So say we did do biopsies, and this is a boxer. He's 2 years old. He's had large bowel diarrhea for the last 4 months with tenesmus and hematochezia. We do endoscopic biopsies, which are normal in the proximal bowel and show neutrophilic pyogranulomatous inflammation in the colon. Is that ringing alarm bells for anybody?
Yes.
What's our diagnosis?
E. coli adherent boxers get that. It's a very
good. Excellent. What's the etiology? You said it, E. coli adherent.
yeah.
But why are boxers, and is there any other breeds?
Frenchie.
Great. Why are they prone to it?
Genetics, there has to be a mutation somewhere.
There is a mutation and they know what it is. And it's really exciting. So I want to
Which breed, sorry?
Boxers and Frenchies.
Oh, Frenchies.
Yeah.
What's the name for that condition? Sorry, I missed that too.
Histiocytic ulcerative colitis.
Oh, yeah, okay.
So the boxer colitis, typical boxer colitis. They've kind of gotten to the bottom of it, which is really interesting. So boxers, dogs that are affected by this gene have defective ability for neutrophils to kill things. So they phagocytose the bacteria and the bacteria just live inside the neutrophils. They can't kill them. So they've got a lysosomal deficiency or immunodeficiency, and that manifests in the colon with enteroinvasive E. coli living in the walls of the colon. And then because there's an intracellular infection there, you get a combination of both neutrophil infiltrates, and then you get histiocytic infiltrates, and then you get fibrosis and all of the kind of sequelae that result from that. So what extra tests can we do on our biopsy sample to confirm our diagnosis?
You can do the PAS
Good.
stain.
Yeah, and that will document.
All I know is that if it's positive or negative, but I don't know the specific.
It will just document the intracellular bacteria. Any other fancy tests that we'd have to send to a different lab for?
Is there genetic testing for this or for the mutation?
Oh
Or?
my gosh, I really should know the answer to that question. Sorry.
It's probably a SNP rather. Is that one of the single nucleotide polymorphisms?
It is, yeah.
Probably, I doubt it then, because Cornell would be the only people that are doing like SNP testing.
Okay.
I think. What about the peripheral, like the serum biomarker, peripheral anti-neutrophil something?
Panka?
Yeah.
Yeah. I don't know what the actual words are, but Panka?
Yeah, that one.
Yeah. So Panka is excellent. So this is like a biomarker for neutrophil activity that they're testing on in feces, and it's elevated way before clinical signs develop in dogs with histiocytic ulcerative colitis.
Mm-hmm.
And there's kind of like, it's quite well established, there's a cutoff. I've looked recently and we can't do it in Australia.
And you can't, that wouldn't differentiate this type of IBD versus others, probably.
It wouldn't, but it's quite specific for neutrophil activity. So I would say neutrophilic neutrophilic inflammatory bowel disease is quite rare, and this is by far the most common cause. So if you've got a consistent breed and an elevated Panka, then I'd be pretty convinced of my diagnosis.
Yeah.
So is that a serum test or a histo test?
A fecal test.
Oh, fecal, sorry.
Yeah.
Okay. Oh, so you don't even, if you got the right breed, you don't even need to do the biopsies, you run this test.
Yeah, exactly. If we could run it, but we can't. So we have to do the
we can't run it.
No.
Oh.
And what about decreased fecal IgA specifically to differentiate this, or that wouldn't be that, because that's, I think, associated with chronic enteropathy in general, but
exactly
differentiate.
Non-specific for this, but a potential marker for more chronic enteropathy. That's interesting that's seen in German Shepherds with no histologic evidence of inflammation. So it's not actually a marker of inflammatory bowel disease.
Yeah.
It's a marker of dysbiosis, really.
Yeah.
What
about fish of the adherent E. coli?
That's exactly what I was going for. So actually on the histo, what's fish?
Fluorescent immunochemistry, something, histopathology. I don't know.
Okay. So it's fluorescent in situ hybridization.
Hybridization.
Yeah, but I don't really know what that means. All I know is that they put this fancy stuff on the histo sample and the bacteria light up, they fluoresce. So that's how I remember it. So it's looking for bacterial DNA in histo samples. So it's not so dependent on, like, obviously they've been formalin fixed. The actual integrity of the bacteria is probably disrupted, which means your PAS and stains like that aren't as reliable. But if you've got bacterial DNA in there, then it fluoresces, and you can say it's definitely intracellular bacteria.
Hopefully, I'm glad to hear that formalin's enough to kill it.
Yes. Okay. So what are we going to treat these patients with?
Enro,
How long?
2 weeks.
No.
Longer. I think
Longer.
4 to 8 weeks.
Yeah, so 6 to 8 weeks. So if you do shorter course of enrofloxacin in these dogs, you're predisposed to resistance development. You need to clear all of the E. coli out of these dogs completely. And then hopefully they repopulate with non-enteroinvasive forms. But this could obviously relapse. If that bacteria gets in there again, there's the same immunodeficiency still existing. So we're going to get the same response.
Can you encourage that with microbiome manipulation?
You can, but it's so prevalent throughout E. coli is everywhere. So it's easy for them to be reinfected for sure.
Manipulating the acidity of the hindgut, would that do much for E. coli? Probably not, because it'd just be looking at because even this is where a symbiont E. coli could become a pathobiont.
Yeah, absolutely. Yeah. I don't know what impact we can make with acidity. I haven't seen any research on it. I'm interested.
I think for salmonella you can, but E. coli, I think it kind of lives there.
It's everywhere.
It's trying to tell us to stop breeding Frenchies.
It really is. Yeah. Okay, so we've got 2 minutes. What we obviously didn't get very far into the histo or anything. Sorry, everyone. But say this wasn't Say this wasn't a granulomatous colitis. Say this was a profound protein losing lymphoplasmacytic inflammatory bowel disease, idiopathic bowel disease. What is your treatment approach going to be in this patient? It's profound inflammation on histo.
Corticosteroids.
Yeah.
With such profound cases, do you start a second immunosuppressive straight off, or do you wait for a bit?
It depends how unwell they are, and also whether they've got any breed-specific reasons why they won't tolerate breed or comorbidity reasons why they won't tolerate pred very well. Most of the time, if they're young, healthy dogs who aren't staffies or golden retrievers or Labradors, I will just start pred. But if they're large breed dogs or not going to tolerate it well, I'll start. Depends. So what's your second choice for immunosuppressants in the IBD?
For a dog, maybe azathioprine can use.
Yeah.
It just takes 14 days though. You have to bear that in mind that it's going to take 14 days too.
Yeah. Newer research suggests that there's decrease in cytokine levels after 5 days. So it is a little bit faster than what everybody always used to say, 2 weeks for azathioprine, but there wasn't actually a study that said that. It was just in theory, that's how long it should take. But yeah, now they're sort of saying it probably has some effect earlier.
What about concurrent metronidazole and corticosteroids to start with?
Very good paper by a very good group that was a kind of prospective, double-blinded, very well-run study that looked at pred plus metronidazole versus alone. No difference. Yeah.
And if they couldn't handle pred, I know it's not as good in humans, but would you maybe go to budesonide before azathioprine? Or
potentially, yeah, absolutely. So the reasons why I wouldn't use budesonide is if the stomach's involved. Do you know why? No. So budesonide is activated to its active form. Good point. But what actually happens is that budesonide works locally, so it works by local contact with the bowel, but it's not its active form when it's swallowed. It's converted to its active form through enterohepatic circulation. Yeah. So it gets absorbed into the portal vasculature, goes through the liver, gets converted in the hepatocytes to its active form, and then excreted in bile. So it only actually works on the enterocytes south of the bile duct.
Yeah.
So you're not going to get any anti-inflammatory in the stomach unless you're getting reflux of gastrointestinal, of intestinal contents into the stomach, which is not ideal, which we're trying to avoid.
Yeah.
I've also heard now that because when I went to school, this had just come out and they said the systemic side effects are minimized. But now studies are coming out that it's not as effective and bread is a better, I would say.
I think that what the studies showed is that we still get really profound impact on the adrenocortical axis. What is it? Pituitary adrenal axis. So budesonide is absorbed and has systemic effects more than we thought it did, or more than it is in humans. So the advantages of using budesonide over pred are kind of like, well, if we're getting side effects anyway, what's the point? Budesonide is much more potent than prednisolone. So theoretically, if you're still getting suppression of the pituitary adrenal axis, you might actually have kind of, I think it was 32 times or something, the potency in the bowel. So I don't know. I have to say I don't reach for it often. I usually reach for a second agent rather than budesonide. And particularly what I usually do with these patients is hit them pretty hard up front with an anti-inflammatory, but also at the same time modulate diet and microbiome where possible. And usually then use that to maintain. So I'm trying to get rid of the inflammation, which is going to restore the mucosal barrier. And once I've restored that, I can then usually rely on keeping the microbiome and the food antigens moving through stable, not reactivating that inflammation. And then
if you're going to corticosteroids at a defined time point, would you do an immediate antigen break from food by going on to hypoallergenic or hydrolyzed low-fat diet at the exact same time? Well, I mean, pending hyperexia, but obviously they're going on to steroids, and that would be the opportune time to double up on antigen break.
Absolutely. So we just kind of clean slate them. So we usually do that all at once, typically.
What about sulfasalazoline if they can't handle steroids?
It's just not effective enough.
These ones are critical ones. You just want to go to a second line straight up.
Exactly. Yeah. So if we've got a protein losing enteropathy, I'm not messing around. They're going straight on pred.
Yeah.
If it's not protein losing and it's just kind of, has diarrhea twice a day and the poos are never formed, then absolutely I consider a less kind of impactful option other than pred. But yeah, once they're fully sick, there's no substitute for pred.
Just to clarify, you said obviously modulate the diet at the same time to decrease the antigen response, but the microbiome, so you just said before that with the corticosteroids and made no difference if you add together, if it's a very sick patient with idiopathic IBD. So then how do you modulate the microbiome? Just with the diet?
Exactly, with a diet and probiotics as well, potentially. So it's not uncommon for me to send these guys home with a jar of prednisolone. I really like the ADM brand probiotic supplements just because of the studies they've done on them. And there's one called Enterogenic now, which is a fairly new product which has probiotics and cobalamin and prebiotics in it.
And alpha-butyric starch for gut lining.
For gut lining. So it's a really nice supplement that's just, I don't like overloading people. I think they get very overwhelmed. But if I can give them one supplement that does all of that kind of microbiome modulation, as well as cobalamin supplementation, as well as doing a hydrolyzed diet, so decreasing food antigen moving through, that's usually my go-to in severely affected dogs. And then
is this ADM brand a human brand?
No, ADM is a veterinary manufacturer. They do procolin.
Oh, okay. I use procolin.
Yeah. So procolin, symbiotic, and then enterogenic is, and they do cobalazorb as well. And enterogenic is kind of like all three stuck together, basically, plus more.
Yeah.
It just has soy in it. Like one of the flavors I do find is antigenic. So I do find that dogs can handle like cobalizorb way easier than they can handle procolon enterogenic. And then the other thing is like what was more historically used in pet food was like FOS. I think fructoooligosaccharide.
Oh, yeah.
I have to jump onto another meeting. I'll see you guys later.
Yeah, thanks, Matt. We should actually
have a good weekend.
I can't remember what the next topic is. It's going to be really interesting. We'll see you in a fortnight.
Thank you.
If you've got any questions, email them through.
Thanks, Anna.
All right. See you.
Thank you. Bye.
Bye.
Thank you. Bye.